So yes, I'd like to give our presenters a warm welcome. Francis Gardner and Sophia Backhaus will be presenting on the work that they've led on the WHO guidelines on parenting interventions to prevent maltreatment and enhance parent-child relationships for children ages 0 to 17 years. I'm just going to do a brief introduction of the speakers before handing over to them. So Professor Francis Gardner is a senior researcher was Senior Research Investigator for the GPI. She's also the co-principal investigator for parenting within the preschool system in Malaysia, and as well as a co-investigator for the parenting on the Thailand and Myanmar border and parenting within the public health system in Thailand. She's a professor of child and family psychology at the University of Oxford, and the co-director of the Centre for Evidence-Based Intervention at the University of Oxford. And then Sophia Backhaus, who is a doctoral student at the Department of Social Policy and Intervention, also at the University of Oxford. She was the co-researcher on the WHO Parenting Guideline Development Project and was also entrusted to write these guidelines. Her research focuses on the effectiveness of parenting interventions to reduce violence against children, and she's also interested in the measurements of violent parenting behaviors. Sophia has worked with WHO on various projects related to violence against children, parenting, and early childhood development. I'm going to hand over to Francis to take us away, and then about 40 minutes, Francis, to present, and we'll do some Q&A as well. Thank you.
Thank you. Lovely to have everyone here, even though I can't see you. We were incredibly honoured to be asked to do the underlying research reviews for the WHO guideline on parenting interventions to reduce maltreatment. So we're going to tell you a bit about some of the underlying research that we covered, but before that I'll give you a brief introduction to the guideline itself. Next slide. Next slide. This is the guideline document. Next slide. And this is where you can get hold of these documents. There's the guideline itself, which is the summary of the evidence and its recommendations. And then there's the 2 reports on the underlying evidence, which is the work that we did and we're mostly going to talk about here. And that includes the systematic reviews of the effectiveness of parenting programs, but also some reviews called the integrate reviews, which we got very interested in, which ask quite a lot of different questions apart from what works in parenting interventions. Next slide. First of all, most important, thank you to the amazing reviews teams. They're almost all people from the Department of Social Policy and Intervention at Oxford, and most people are also at part of the GPI. So it's a really huge GPI effort and a really wonderful team. Next slide. So how do we define parenting interventions? These are interventions that aim to improve parent-child interaction and the quality of parenting. They're structured interventions directed at caregivers. They focus on developing new skills and behaviours, and not just about imparting information or didactic instruction about what to do with your kids. So parents need to learn and practice and discuss new skills that are suited to their own child and their family context. And these programs are often manualized to help ensure consistency and fidelity. They can be universal, offered to all families. They can be selective to families perhaps at risk for maltreatment, or indicated prevention, which is families already identified as having problems with maltreatment or other kinds of problems that might need a parenting intervention. Delivery can be to groups, but also can be to single families in the home or in a centre. And as well as being centre-based or home-based, delivery channels can also be digital or a mixture of these things. Delivery staff may be professional or paraprofessional or sometimes lay workers, and these programs may be combined with other components addressing different outcomes, such as household income support. Next slide. Quite a lot of research has taken place about the essential components of effective parenting interventions. I'm not going to go through all of these because I think they're fairly familiar. But the key is building strong and positive parent-child relationships, finding alternatives to non-violent discipline. Next slide. And again, just as a reminder, crucial to these interventions, it's not just about practice. It's not just about knowledge. It's about practice. And I think we've all probably experienced in our own lives how hard behavior change is, and it takes much more than knowledge. When I became a parent, I already knew an awful lot about parenting, and I was quite taken aback how insufficient was that knowledge compared to actually trying to change and even control your own behavior. So there's much more to it than knowledge. Okay, and the guideline recommendations, very briefly, this is what the process came out with. And this is what the guideline development group recommended, that in low and middle income countries, evidence-based parenting interventions should be made readily accessible to all parents or caregivers of children aged 2 to 17. We conducted a global review which had a slightly narrower focus, and this review recommended that interventions informed by social learning theory, which Sophia is going to say more about, should be made readily accessible in the age group around 2 to 10 years. And further, that in low middle income countries, these interventions should be made accessible to parents of teenagers, but in formats that consider the specific needs of adolescents and their parents. And then for all these recommendations, there was the additional comment that they could be group-based or individualized, could be delivered through a variety of stakeholders, including government organizations in settings such as health or educational social services or NGOs. Next slide. Then there was a further recommendation that parenting programs should be offered in humanitarian settings, with the additional point that formats need to consider the impact on recipients' mental health. And then finally, there was a recommendation about early child development in the first 2 to 3 years of life. We didn't repeat all the work on early child development because there'd been a very recent 2020 WHO guideline on early child development. So our recommendation was to repeat theirs, which is that all infants and children should receive responsive care during the first 3 years of life, and that parents and caregivers should be supported to provide this. Next slide. The guideline development process, I'm not going to go into this, but it is quite formal and rigorous. It was quite long. I think we started in 2019. I was going to get Sophia to remind me when it was. And there are checks and balances at many points and needs approval from higher up in the WHO at each stage. Next slide. So first of all, what did we find in the systematic reviews of evidence of effectiveness of parenting interventions? Next slide. Overall, across those reviews in different age groups and settings, we found strong evidence from randomized trials across the world. There was a total of, at that point in time, there will now be quite a few more, 435 randomized controlled trials of parenting interventions from 65 countries. And the green countries are the ones where we found trials from our searches. And overall, the evidence suggests that these interventions reduce harsh and negative parenting behaviors, including maltreatment, improves positive parenting and nurturing parenting behaviors. Next slide. So these were the research questions for the 5 systematic reviews that the guideline group decided that we should focus on. And next click. And these are the 3 that we're going to focus on today. the review for families living in low and middle income countries, aged 2 to 17, families globally with a narrower age range, and families living in humanitarian settings in low and middle income countries. Next slide. And these are the guideline outcomes of interest across all the reviews. Firstly, child maltreatment and its subtypes, including child neglect, physical abuse and emotional abuse. A more general category of harsh parenting, which overlaps, of course, with maltreatment. Other kinds of negative parenting, such as inconsistency or poor monitoring. Positive parenting skills, which includes responsive parenting in response to a question that's come up in the chat, which we can come back to as well. Parenting stress, parents' mental health problems, and important child and emotional and behavioural problems. So many parenting interventions have focused on these problems, child behaviour, as well as harsh and maltreating parenting. Next slide. So first of all, the results of the lower middle income country 2 to 17 review, and then Sophia will talk about the global social learning theory review and the humanitarian review. Next slide. So our question for this review was, how effective are these interventions compared to an inactive control condition? So where people who got the intervention were compared with something relatively inactive or inert, such as services as usual, which in most places means nothing, or a waiting list or other kind of control condition where they didn't get the intervention. We undertook highly sensitive exhaustive searches. We looked at 26 databases, including 14 that were in non-English languages. We looked at the grey unpublished literature and at registries of randomized trials across the world. We searched in English, Spanish, Chinese, Thai, Farsi and Russian, and we're also able to translate papers in those languages. And the whole review was pre-registered. Next slide. The striking thing was the huge increase in rigorous impact evaluations in low and middle income countries over the last 10 years or so. So at this point, when we conducted these searches in 2021, we found 131 randomized trials of parenting interventions in this age group. And this is an extraordinary increase since our review that we published in 2013, where we only found 12 trials in these countries. Next slide. So where were the trials? They were in 32 different low and middle income countries. Most of these were middle income countries, so the evidence base is relatively small for low income countries. The darker colours are the ones with more trials, and you can see the darkest colours are China and Iran. There's an extraordinary number of trials in Iran. But other countries that had quite a substantial evidence base included South Africa, Mexico, Brazil, Turkey, and so on. Next slide. How were the interventions implemented? Most families were poor, often living in contexts of adversity, although there were some trials conducted with urban middle classes in middle income countries, but they were quite a minority of the studies. Most of the interventions were delivered in a group format. Some were part or fully digital. Mainly they were delivered to mothers, but also some to fathers, grandparents and other caregivers, most often in mixed together rather than running separate programs for those other caregivers. Most focus on either preventing harsh parenting or on reducing child behaviour problems, but the interventions were very similar, regardless of those primary sort of goals of the programme. The delivery settings were quite a mixture in healthcare, community, school. I'm sorry to report that the largest group was those where the authors didn't tell us what was the setting of the programme, which was frustrating when you're trying to review this information. Mostly they were delivered by professional staff. Only 6% included lay workers. The remainder was semi-professional or not stated in the paper. So I think we can see already that there's a gap in the evidence base about working with lay workers, which could be really important for scaling up, but we need to know more about the effects. Next slide. The results showed that parenting interventions in lower middle income countries are effective for reducing all key outcomes. And these are the effect sizes in the first column. The effect sizes using Cohen's D, the larger the number, then the greater the effects. And these are all significant, highly significant statistically effects. And you can see effects on child maltreatment, harsh parenting, positive parenting, child behavior problems, parent depression, anxiety, stress, and other forms of negative parenting. Next click. Just want to note that compared to the global evidence that comes largely from high-income countries, then the effects in lower middle-income countries are at least as high and sometimes higher. And it's particularly noteworthy with parent depressive and anxious symptoms, where we get a pretty substantial effect size of 0.57. And that's, can be as high as you get with alternative treatments for depression, that kind of effects. I think that's quite important when we think about the global burden of depression across the world. Next slide. For whom do they work best? We looked at moderator effects and asked, are the differential effects by different kinds of families, children, or contextual characteristics? Well, interestingly, we found very few differential effects. Parenting interventions appeared equally likely to be effective across different levels of family poverty, education, age of the child, or country income level. So things that common sense might say were important in determining outcomes, such as if parents are very low educated or ultra poor, is that going to make it more difficult for a parenting intervention to be helpful for them? Well, that doesn't seem to be the case here. But as has been found in many other studies, the changes that you get tend to be greatest for families who are concerned about their child's behaviour. And indeed, that was originally how these programs were designed to work. Next slide. What about the program and delivery features as moderators? Do they make a difference? Well, interestingly, there was no greater effect for programs that were longer. And in fact, if anything, the trends went in the opposite direction, with shorter programs tending to be more effective. And that's interesting, given people are often wanting to add more and more to a program. But of course, that also makes it more expensive and potentially more burdensome for families as well. Group-based and single-family programs appeared equally effective, but of course the likelihood is that in most contexts, group-based ones will be cheaper and possibly more fun for parents. Imported programs were equally likely to be effective as ones that were homegrown, and I think that's really important because we worry about programs being imported from one country to another and whether they won't be acceptable or effective. But in this case, the programs that were imported mainly from high-income countries and adapted were just as effective as those developed in country. And then the important question about lay workers, there were too few trials to test the question about whether the effects were as strong with lay workers. The trends were towards the effects being stronger with professional workers. So I think that's something, it's an important area of development and dissemination. Next slide. Now I'm going to pass over to Sophia, who's going to talk about the humanitarian review and then about the global social learning theory review.
Okay, thank you, Frances, and thank you everyone for joining this webinar today. Yes, as Frances mentioned, I would like to start to talk about the humanitarian review. So first of all, in this review, we focus on families of children that live in humanitarian settings in low middle-income countries. And for this review, which is kind of a sub-review of the LMIC review that Francis just presented, we widened our inclusion criteria slightly. So in this review, we also include the age population 0 to 2 years, and we include interventions that have not only a parenting focus, so even interventions that are multi-component interventions and maybe with only 20% of the interventions focusing on parenting. The reason for this is because we know that in humanitarian settings, a lot of interventions are delivered as multi-component interventions due to a scarcity. So why do we focus on this age population and these children living in humanitarian settings? We know that formal services, particularly parenting support services, are frequently disrupted. But families are really a key system that are there to provide the nurture and care children need, particularly when we look at the younger age group, the 0 to 2 years. But we also know that parents are often compromised by the suffering and the exhaustion in the aftermath of a humanitarian emergency. And they may face additional stresses related to the resettlement of those families. In total, we found 18 randomized controlled trials with a range of goals in the included interventions, such as reducing violence, but also focusing on parent-child trauma or mental health problems in these families. And most trials were delivered and implemented in Africa and the Middle East. If we now zoom into those settings, we see a range of countries that are included. We see one trial coming from Colombia and one from Bosnia, so from Latin America and Europe. But as I said, most trials in Asia, including the Middle East, such as Myanmar or Nepal or Palestine, and in Africa, such as the Democratic Republic of Congo, Liberia, or Ethiopia. Most of these trials also focused on post-conflict settings, followed by including families that are from a refugee population, families that are living in a current war or conflict zone, and only one trial, the trial from Nepal, that includes a family that are living in the aftermath of a natural disaster. So there's really a scarcity of trials from these type of humanitarian settings. What did we find in this review? So across these 18 trials, we found that parenting interventions that target those families, actually these families in quite high need of parent support, reduce overall negative parenting behaviors in those families, including harsh parenting, but also ineffective parenting behaviors. They also improve positive parenting, for example, better communication with a child. However, we must caution here that the number of trials was relatively small, particularly when we look at different outcomes. So not all of the 18 randomized controlled trials provided outcome data for all outcomes of interest. So we found some rather promising trends for improved parent mental health and child behavior, but we really cannot say anything about, for example, reduction in child internalizing behaviors, such as child anxiety, because this was really not measured often enough in those trials to merge the data and find an effect. Moving on to our global review. So the global review currently constitutes the largest parenting intervention review in our field. And this review, as Francis already mentioned, is based on social learning theory and for the age group 2 to 10 years. The reason is that this is the age group that is most targeted and is also where the onset of child behavior problems often is related to. And social learning theoretical programs are also the most widely distributed parenting programs. We included here also randomized controlled trials and used again a highly sensitive and exhaustive search. We could also make use of the LMIC review search, since this applied to multiple languages. It was very sensitive to fine gray literature and had wide inclusion criteria. So we could only include those trials that were relevant now for this review. But what is social learning theory? So I just want to give you a very brief introduction. If you follow social learning theoretical principles, we believe that violence between parent and children is often unwittingly reinforced by, for example, reward or punishment. In addition, children learn by modeling parent behaviors. This may include positive behaviors such as helping other people, but also negative ones such as violent behaviors. A typical description of social learning theory is the coercive cycle of parent-child interaction, which can be applied to parent-child violence. So I just want to walk you through that briefly, that you get an understanding of how the violence between parent and child sometimes occurs. So it often starts with the parent making a request or saying no, such as asking the child to clean the dishes. The child may refuse or ignore this request. To this, the parent may start getting quite irritable or starts yelling at the child. The child may now model those behaviors and gets irritable or starts yelling as well, or may escalate in a tantrum. To which the parent may respond with even harsher forms of emotional violence or physical violence, such as hitting or slapping the child. This may further escalate in a spiral with more hitting and yelling from parents and children. Now, at some stage, the situation will come to a conclusion by either the parent giving up or the parent succeeding. But in any way, the violence between the parent and child is reinforced. Because when the parent gives up, for the child, the tantrum is reinforced. So the child learns, oh, I just have to model my parent. I may have to yell or shout or show forms of aggression. And in this form, I don't have to do what my parent tells me to do. However, if the parent succeeds, so the child in the end does clean the dishes, the escalation of the parent is reinforced. The parent may learn, my child only listens to me if I use some form of physical or emotional violence. So with social learning theory-based interventions, we try to break this coercive cycle by showing parents new behavior management strategies to react to non-compliance of a child. This may be related to applying logical consequences, ignoring negative attention-seeking behaviors by the child, or setting clear family rules. Now back to the review. As I said, this is the largest review to date, and we included for the WHO guideline for this review 278 trials from 33 countries. You see here a color coding by income grouping of a country. You will see in green high-income countries. Unfortunately, even though it is a global review, the majority of trials are from high-income countries, with most of the trials being implemented in the United States. But you also see in blue that we actually found quite a lot of trials from upper middle-income countries, less so from lower middle-income countries, and unfortunately only one trial from a low-income country that fulfills the inclusion criteria for this review. So to how and to whom were these interventions delivered? As we found with the LMIC review, we also found in the global review that most interventions were delivered to mothers. However, there were a lot of attempts to include only fathers or other key caregivers in those interventions. Some interventions also only focused on single parents. We found that most families were from a disadvantaged socioeconomic background, and that most interventions were delivered in a group format. The most evaluated intervention brands were P, followed by Incredible Years, the Parent-Child Interaction Therapy, and the Parent Management Training. We also included Parenting for Lifelong Health trials, because also Parenting for Lifelong Health is based on social learning theory. And the majority of interventions were homegrown, meaning most of them were tested in the country they were developed. However, especially in the past decade, we see more and more interventions being tested in a transported setting. So they are tested in a setting where they are not originally developed. So what
Sophia and Francis, I just want to give you a 10-minute warning.
Okay, thank you. So what did we find in this, this review? We found a reduction in all key outcomes of interest as stated by the guideline development group, including physical abuse and psychological abuse. But unfortunately, we could not really find an effect, or we could not establish an effect for neglect because not enough trials included neglect. Now, we updated the review since the past search that found the 278 trials was conducted in 2018. So with the new search in 2022, we found even more trials from even more countries. With this update, we really had two goals. We wanted to unpack a bit more what do we mean by measuring violence, and also what is the longer term effectiveness of these interventions. So when we measure child maltreatment or harsh parenting, we find different outcomes, but it's really hard to distinguish these two constructs from each other. So if you look at on the left-hand side, these are some example outcomes, but which behaviors would you group under harsh parenting and which under child maltreatment? In fact, we know that the instruments quite overlap in the behaviors they include. So in the update, we included any violent parenting behavior, regardless of if it's called harsh parenting or child maltreatment. We also wanted to know if these interventions are even effective after 6 months or a year after parents have been enrolled in the parenting interventions. So what did we find? We found that these interventions definitely reduced violence against children. The strongest effect was immediately after parents having participated in an intervention, so 0 to 4 weeks after the intervention. But we also found effects even 1 to 6 months after the intervention, up to 7 to 24 months. Unfortunately, we didn't have studies beyond 24 months or 2 years. You see the effects are a bit smaller, so we really need to understand how we keep this really strong effect that we found immediately after the intervention, also over time. But the good thing is the effects remain there, so we still see a reduction in violence over time. And back to you, Frances.
Hi. We'll try and keep this part to 5 minutes because of time, but I really hope to have more conversations about these reviews, which are called the Integrate reviews, because they're really interesting and there's an awful lot of material in there. Perhaps we can do a talk sometime just on this. But to give you a flavour of the Integrate reviews, next slide. Okay, so what are these about? So what we've got are hundreds of rigorous impact evaluations showing that parenting interventions are effective for reducing maltreatment, improving positive parenting, child behavioural problems, and so on. And the effects appear to generalise across a wide range of settings, cultures, ages, and families. But to make complex evidence-informed decisions, what else might a policymaker or other decision maker need to know? Well, the WHO Integrate is an evidence to decision framework, which attempts to ensure that all the other important factors that you might need to think about to make a decision are considered in a systematic and transparent way. So these criteria were used to inform the recommendations as well as the effectiveness. Next slide. Just to think about what Integrate means, this is a quick quiz. I think because we haven't got very much time left, I'm probably just going to walk you through this. But just think, if you wanted to implement a parenting program, say in communities in northern Nigeria, and you wanted to address the problems that families are having with caring for teenagers in a conflict zone, you've learnt about a program that's been tested in similar settings. You've read the evidence from the humanitarian review that these interventions may work for protecting teenagers and keeping them safe. But what else might you want to know before deciding if you were going to use or fund this program? Next click. You'd want to know things like, will the parents and the community leaders like this program? Will they approve of it? Are there any adverse effects on people? How feasible is this intervention likely to be here in this setting? Who will do it and in which system? Is the intervention ethical and in keeping with human rights principles? How much will it cost? Is it likely to be cost effective? Will there be wider benefits or burdens for families or for society? And will it have equal effects on different groups in the population, or will it favour some people more than others in its effects? Next slide. And this is the a formal kind of model of the WHO Integrate system, which puts together these different questions about the balance of harms and benefits, the human rights aspects of a programme, its effects on health equity and equality, and financial and feasibility considerations. Next slide. So to investigate these questions, we conducted a series of mixed methods reviews, drawing on qualitative data from over 200 studies of what parents and children and delivery staff think about the acceptability of interventions, their potential harms and their feasibility. Where we did a child rights-based analysis of programs, and we also drew on quantitative data from the systematic reviews to ask questions about harms and equity. And we also synthesize existing studies on cost effectiveness and implementation. Next slide. This summarizes the different methods we use for the different questions, which can be referred to if you want to later. Next slide. So what did the guideline development group conclude about this, looking at all the evidence that we got from these mixed methods reviews? Well, they concluded largely in favour of parenting interventions on all these different criteria. Where they were less certain, for instance, for human rights, they put probably favours the intervention, and for health equity and equality probably favours the intervention, and the financial considerations was partly because there tended to be fewer studies about these questions in low and middle income countries. So we didn't want to have, we wanted our confidence to be a little bit more sort of cautious. And as for feasibility, we felt it was very hard to make an overall judgment because it depends so much on the context and the resource, the human and other resources in that context. Next slide. Because of time, I'm just going to take you through a couple of these, what we did and what we found. The balance of health benefits and harms. This used very much the kind of hard quantitative data and qualitative data about what parents thought about these interventions. And it was pretty clear from the meta-analyses of the effects of these interventions that the evidence was very consistently in the direction of beneficial effects for all outcomes, and we couldn't find any evidence of harms there. But also parents very rarely reported harms across 217 studies globally. So they didn't, they rarely reported things they disliked about programs, but even less did they report about anything that they might have thought was harmful to their family. Next slide. And then the approaches that we use to look at health equity. So here we're interested in whether parenting interventions are likely to increase or decrease or have no effect on inequalities that already exist in societies. So what do we do for this? Well, the main method was the meta-analyses of moderators, where we're sort of comparing across trials, whether trials that have families that are more disadvantaged do have better results than ones that are less disadvantaged, and so on. We also conducted reviews of moderator analyses within trials and reviewed individual participant data meta-analysis of these questions, which is the kind of gold standard. But with all kinds of methods, we found that we couldn't find any evidence that these programs were likely to have adverse equity effects. Rather, it seemed that they were equally likely to be beneficial for different groups of parents and families, such as children of different ages, parents of different levels of poverty and education, and different levels of country level poverty as well. And obviously, where parenting interventions especially target families who are in need or who are particularly poor, then the chances are that they're likely to, by doing that, reduce inequities. But of course, we have to remember there's always the potential for inequity of access. Our data was about inequity of outcomes once people actually attempt to access a programme. And obviously, providers need to pay very careful attention to accessibility, especially for the most marginalised and low-income families. So things such as the location, the timing, and providing food and other ways to make the programmes more accessible. And having programmes being shorter, which we saw were just as effective, and digital programmes, which the GPI is making great strides in developing and assessing, this may help. I'm going to leave you with the next slide, and the next slide, and the next slide, which summarises the results about those other areas of integrate. I hope we can talk more about the details of those results sometime. So just to conclude and wrap up, parenting programs in all stages of childhood seem to work well for a range of outcomes, both globally and in low middle income countries, including parenting outcomes, as well as child behavioural and emotional problems. And they also seem to be beneficial for a costly and very high prevalence outcome, which is parent mental health problems. And it's interesting that we got strong effects on these in low middle income countries, despite parenting programs not directly addressing parents' depression, but they're obviously helping with it because of helping parents to get on better with their kids and feel more successful in that way. And similar programs in children aged 0 to 3 seem to enhance cognitive and language development. So parenting programs seem to address the multiple complementary needs of vulnerable children and families. Next slide. They seem to transport well across countries and cultures. They're beneficial for a range of families and contexts, including humanitarian settings. Short active learning group-based programs seem to work as well as longer ones, if not better. And these programs appear to be socially acceptable from the Integrate reviews, to be in line with human rights principles, to be cost effective, and not to cause harms or adverse equity effects. There are limitations in the data. Often the certainty of evidence was low to moderate, and there are relatively fewer long-term studies, but those that they're promising for some outcomes. And the guideline development group raised a lot of research priorities about digital programs, especially in low and middle income countries, how to embed programs in systems so that they can be scaled and sustained. What are the longer term effects of these programs? How can we include fathers, grandparents, and children and adults with disabilities in these programs? Thank you. Thank you to all our partners, and another copy of the links to the documents. Next slide. There's meant to be a slide saying questions, please.
Thanks, Frances. Thank you, Sophia. We do have a number of questions, and I can share. Yeah, I can just share that. I've also saw that, Frances, you've actually answered quite a few questions in the chat. So there's some of that there as well. But I'll just share screen with questions that had come up during the session. Oh, there's quite a few extra now. So let me do this. The first question was around what is the reason for the age difference between the recommendations for the global and LMICs?
Okay, I put an answer in the chat.
Okay, so that is there.
Yeah, and it was related to the fact there's already a guideline on very young children. We didn't want to repeat all of that, but it's also related to the fact that the kind of nature of the program's changes around age 2, because you have responsive parenting is kind of fundamental for all ages of childhood. But then added into that, once you get to about the age of 2, sometimes a bit earlier in some programs, there's much more focus on dealing with discipline and non-violent discipline methods. So we saw those as different kind of programs needing a somewhat separate review. But we didn't then repeat the 0 to 2 review because it had already been done in another WHO guideline. But we did update that, so we have some further data about some of these parenting outcomes in that chapter in the reviews.
Sure. And then I'm not sure if we should go through all of them. Frances, I'm not sure which ones you've actually answered now. Was it only the first one that you've answered in the chat?
Oh, right. There was the age difference. I can't see. I did answer another one, but I can't see it.
Yeah, because I think one of it must have gone directly to you. So we can work through the ones that we have up on screen now. Were the interventions that were focused primarily on male caregivers? If so,
Yeah.
were the results disaggregated?
We would have loved to have disaggregate ones that had a primary male focus, but there were too few to put that into the analysis. But I think you can find within the review, find papers, individual trials that had a focus on male caregivers or on couples.
Sure.
But obviously, and that's a big, that's quite a big focus in some of the GPI studies. So really important question, but there just wasn't the data to analyze it like that.
Mm-hmm. And that's a similar question in question 3 as well. And then question 4 was around LMIC review. Does the evidence that shorter interventions tend to be more effective than longer interventions, and the evidence that effects tend to be universal across subgroups imply that there is currently very little basic parenting support available in LMICs, and that there are substantial potential benefits to be had from the provision of even very basic parenting support?
I don't think our reviews don't tell us what basic support is available. They tell us what interventions have been tested in formal evaluations and where. But they do suggest that there might be quite a lot of benefit for fairly basic parenting support. Yes, that was, say in the region of 6 to 10 sessions, or and potentially to get more kind of bang for your buck with digital interventions when we have more results from those from the GPI work.
And then the next was, does the social learning theory also consider domestic violence against women that children also witness, but also affects mothers' parenting skills?
Sophia, do you want to have a go at that one?
Yeah, so generally, yes, social learning theory would consider that, so that children maybe model those behaviors they witness. In terms of the programs that include social learning theoretical principles, we see, so we tested in separate analysis if we find an effect on intimate partner violence, and we do. So it was a non-prioritized outcome by the guideline development group, but since a lot of programs do include nowadays also components on IPV, or do have it in part of their indirect effects, we see already very promising results to reduce IPV.
Thank you. And then how long is the best period of time to measure changes in parenting? What have you found?
Sophia?
I would say the longer the better, if you can have a randomized control design still intact. So unfortunately, the evidence you probably saw, maybe not, but basically most studies look at up to 4 weeks, but then less and less studies are really examining the effects over time. And I think particularly we need more studies that look beyond a year, but even beyond 2 years. So I think, there's really a scarcity of findings to conclude also the really long-term effectiveness of parenting programs. But what we see is a slight decrease in the effect, but an effect still over time.
The next question was around scale up. And so this person had said, in our government context, Sorry, we are considering bending the fidelity principle a bit. Do you have any examples of rigorous evidence-based parenting programs being scaled up without the involvement of the research community and the international donors in LMICs?
This is a really interesting question, and all the examples that are popping into my head tended to have in-country research community or international researchers or international donors involved. I'm wondering, unless someone else can think of an example, I wonder if we could correspond about this. I think this is a really interesting question. It would be great to talk to you more. And I think other members of GPI would like to as well.
Yeah. The last question that I have up, and I think there's a few more in the Q&A. It doesn't look like the inequalities between women and men caregivers, like there are inequalities between women and men caregivers. So how?
Yeah. Okay.
Yeah.
I mean, I suppose it depends obviously it depends which inequalities you mean. And a lot of the focus in public health interventions that are, that are aimed ultimately at children is on inequalities between different groups based on poverty and ethnicity and so on. There isn't clear evidence of an inequality in outcomes between girls and boys in the general evidence base. The inequality between men and women, I guess, is in their parenting roles, and because of men traditionally having a smaller parenting role, then fewer of the studies have been able to focus specifically on men. So yes, there's a lot of inequality there, but it's not. But we were talking about inequalities in other ways.
Yeah. Then the next one was around possibly sharing a reference for comparing parenting programs' impact on depression symptoms or depressive symptoms to other formats of treatment. It feels like the PowerPoint would be useful to policymakers. A powerful point, sorry, to policymakers. Where's the question? Can I see the question? It's actually in the Q&A. I can share screen again. I was trying to just copy it. 1 second.
I'm trying to find it.
Yeah.
I think it's an important, I mean, yes, I think it's an important message for policymakers that these interventions can help with a problem that it might not look on the face of it was going to be addressed by a parenting program. I haven't got a reference about comparing with, good, there's the question. I haven't got a reference with comparing with other forms of treatment. The comparison would be that in meta-analyses that look at the effect sizes of depression interventions, that's not a bad effect size compared to other kinds of interventions. But I'm not an expert on other depression interventions, but that's just a very broadly speaking that those effect sizes aren't bad for other kinds of interventions for mental health problems, particularly where it's not a treatment group, it's a group that just are at high risk for depression.
And the next one, I'm going to share screen again, just easier for you to see it as well. So is there a better outcome for shorter program due to the timing of evaluation? So evaluating right after the program finishes, whereas in the longer programs, it might take a bit longer.
Sophia, do you want to have a go at that one, or shall I?
Yeah, I think it's a brilliant question. I don't know the right answer right away. Maybe you have some first reflections, Frances.
I mean, in longer programs, they may still evaluate right afterwards. So I'm not sure whether that would be a difference. I wonder if, just that maybe you don't get a lot of extra learning by having 20 sessions rather than 10. Yeah.
Yeah, we indeed find that not the longer the program, the better the program. So there seems to be somewhere a magic number, which we still have to unpack of the right of sessions.
Oh, I've noticed we've just hit the hour, and I'm sure there are some people that wouldn't mind staying on the call. So if Frances and Sophia can stay on and just might just answer a few more questions. The two questions that I have up there, the next one was around what are your thoughts on taking a programmatic approach, which may result in difficult decisions for policymakers, versus distilling the core elements of what works and integrating these messages into existing service delivery. I asked this given the complexity of different healthcare and welfare systems and arguments to more iterative evidence decision making.
I may have to think a bit more about this one. Really interesting.
So I think one thing is there seem to be these essential components, but also some level of flexibility that needs to come with parenting programs. So you find in the guideline, and Francis presented it already, like the essential components, the core elements, one may say, of these programs. But you really have to think about the system where this intervention is being implemented in, and how to best adapt it to the existing workforce and key system focusing on families and children. So that would be, I think, so it needs some level of flexibility, for sure.
Yeah, and I think the developments in digital programs are very exciting because they are potentially a way of getting the core elements into a more straightforward and less costly kind of delivery system that may be more accessible for more people. And then the integration into other services becomes, potentially easier, and there's less difficult decisions about which of the multiple needs you're going to try and, address at once in a system.
Sure. The last question, could the language used be considered as being over deficit focused on opposed to being framed around positive child development and improved outcomes for children? Could this deter parental engagement?
That's really interesting. I mean, there's a big focus on deficits and maltreatments and costs and burdens, because that's what seems to persuade policymakers and donors and things to do something. So it's, let's prevent maltreatment, let's stop violence against children. But on the other hand, if you're trying to recruit parents, it wouldn't be a good idea at all to present it like that. And instead, what parents want to think about: how can I get on better with my child? How can they do well in school? How can they respect me more? And things like that. So it's very much those positive messages in recruiting parents, but the negative things often seem to work for the world at large. And how you square those up, because I don't feel comfy with the idea that somehow there's a different story for different people. But I guess that's what happens in practice.
And then the last question, I think I've captured all of what was on the Q&A. Did your review identify issues regarding engagement or targeting those parent-child dyads most at risk? Many RCTs of parenting programs do not address this or detention. Given this, are these challenges for policymakers in deciphering how to implement these programs to reach those families most removed from systems and whom have difficulty committing or engaging to a 6 or 12-week program? Finally, did the review come across home visiting as a delivery mechanism?
Yeah, I mean, home visiting was one of the many, one of the several main delivery methods for these programs. In fact, the history of these programs was that they started with home visiting, actually social learning theory programs, to help families with very, very difficult kids and lots of interpersonal violence in the family. So home visiting, yes. Families who are removed from systems, I guess that really is the key challenge for trying to engage the families that might be most in need, and thinking about the systems that are most likely to have the chance of reaching those families. So, for instance, in work that we've done with GPI in Thailand, it's the community health centre system that does home visiting already and tries to reach those most marginalised families. In another of our GPI satellite studies in Kenya, trying to help families that live on the streets with their children, then the only trusted system for the most marginalized parents to reach is certain NGOs that have been working for a very long time with these very vulnerable communities. So I think that's the challenges of, for the policymakers to think about what on the ground works for recruiting the most vulnerable families.
Yeah. So I'm just having one last look in the chat and Q&A. I think we've actually covered all of the questions. And I'm sure people could reach out to you and Sophia directly if there were anything else and any follow-ups as well. Thank you again for presenting today. We really appreciate it. And I think it's been such an informative session and you've provided with a lot of information. Just to let everyone know, this recording will be made available. So people can definitely go back and just work through it again.
Please feel free to email us. We're very happy to answer questions and more with everybody. That would be lovely.
Thanks, Frances. Thank you so much. Yes, and just thank you for joining today, and also look out for our next webinar, which will take place in 2 months' time. Take care, everyone.